So it's a pleasure to be chairing this session, and it's my privilege to introduce our next speaker, Dr. Naval K. Vikram. He is the Professor, Department of Medicine at the All India Institute of Medical Sciences, New Delhi. And he has been involved in research in the field of obesity, metabolic syndrome, and non-alcoholic fatty liver disease since 2 decades. So, Dr. Naval, I will not come between you and the different types of fat. So I'm sure this is a novel topic, and I'm sure most of our audience would love to listen to what is white fat and brown fat or beige fat, and then maybe yellow fat. So it's again a very novel topic. And over to you, Dr. Vikram.
Thank you, Dr. Meena. I'll share my screen. Yeah. So good morning, everybody. And I thank the organizers for giving me the opportunity to speak in this session of IDEC. It's always a pleasure to be a part of this. So my topic today is brown fat. What are the facts? Is it practical? So adipose tissue, we all know it's just not a cosmetic. It doesn't have only just a cosmetic purpose, but it's a highly complex and highly active metabolically, and works as an endocrine organ, which regulates the whole body homeostasis and secretes several factors, several adipokines, which have been identified. And also it is a site for metabolism of sex steroids and glucocorticoids. Not only adipocytes, other tissues, other type of cells are also there in the adipose tissue, which have their own other functions. Now, the classification of adipocytes is based on a few parameters. Now, they are classically divided into white adipose tissue, brown adipose tissue, and the beige or the bright adipose tissue. Now, the division is based on several factors such as localization, morphology, cell composition, and other things. So coming to the white adipose tissue, it's basically in the subcutaneous, intra-abdominal, epicardial, and gonadal areas. Morphology-wise, it consists mostly of spherical cells which have a single lipid droplet, very few mitochondria, and a little endoplasmic reticulum. The main purpose of this white adipose tissue is to store energy, and it gets activated or it increases in the presence of stimuli like high-fat diet. The uncoupling protein 1 expression is not detectable in this tissue. In contrast, the brown adipose tissue, it is basically embryonal in origin. It's mainly located in the paravertebral, axillary, suprarenal, cervical areas. The cells are elliptical and smaller than the white adipose tissue, and they have multiple lipid droplets, much more number of mitochondria. And they function predominantly in energy expenditure and non-shivering thermogenesis. In this, the UCP1 expression is very high, and this is what drives the function of this tissue. It is stimulated by several factors like cold, catecholamines, beta-adrenergic receptor agonists, etc. Now, the beige or the bright adipose tissue, it is situated in the posterior subcutaneous area and also in the supraclavicular area. And this beige tissue may be, adipocytes may be seen amongst the white adipose tissue as well. The cells are spherical, they are unilocular, but they're smaller than the white adipose tissue, and they have much more number of mitochondria. And they also have a thermogenic potential. And they are also stimulated by various factors by which the brown adipose tissue is activated. Now, browning of adipose tissue, that is conversion of white adipose tissue to the brown, to the beige or bright adipose tissue, is a dynamic and a reversible process. So in the presence of certain stimuli such as cold or beta-3 agonism, the white adipocytes change their morphology and metabolic profile into beige adipocytes, which have increased mitochondria. And when the situation is reversed, that is in the thermoneutrality or in the high-fat diet, so these beige adipocytes which are there, they can again turn back to white adipocytes. So this is a dynamic and a reversible process, and several factors may come into play here. Now, the other factor is that there are pluripotent cells also present in the adipose tissue, which may either recruit themselves and become the beige adipocytes, or they may go into white adipocytes, depending upon the stimuli that they receive. Now, the brown or the beige adipose tissue, basically, it is a diverse. It consists of both type of adipocytes, and the amount and the location depends on the age of the subject. With increasing age, there is decrease in the quantity of brown or beige adipose tissue. Now, the brown adipose tissue develops embryonically, as I said earlier, whereas beige adipose tissue is induced from white adipose tissue by stimuli which causes transdifferentiation. Now, they both have a common morphological and metabolic characteristics. They have a similar factors which can stimulate them, and they have similar functions like non-shivering thermogenesis, energy homeostasis, and regulation of metabolic processes and the body weight. Now, this figure here shows the location of brown fat in humans. As we see in infants, it's mainly in the interscapular and the perineal area, and whereas in adults, it mainly is in the deep cervical, supraclavicular area, axillary area. Now, this is not active at a temperature of 27 degrees, and when we see the same thing at 19 degrees, it gets much more active and can be picked up. So, brown adipocyte is the beauty of it is that it can utilize all kinds of fuel. It can utilize glucose, it can utilize free fatty acids, branched chain amino acids, acyl carnitines, all kinds of fuels it can utilize and convert them into heat, that is the non-shivering thermogenesis. Now, how do we find out the amount of brown and beige fat in the body? This is not easy. It's not as simple as you find out just abdominal fat or as such the white adipose tissue. Now, this can be detected only by imaging modalities and not by simple imaging modalities. The most commonly earlier used modalities was the PET-CT, FDG18 PET-CT. Now, this modality has been used in a lot of studies, which can be labeled by glucose or fatty acids or other respective metabolites. But the problem here with PET-CT lies is that it can detect the brown adipose tissue only when the person is exposed to cold temperatures, but not in the thermoneutral state. And this is the problem which we have also faced. We have tried to do a study on this, but there have been a lot of difficulties with that. Now, the other newer modality is the fat water MRI, which offers the advantages over the PET-CT, and it does not involve exposure to radiation. And this is coupled with the functional MRI and dual energy CT. These also have been used in to measure the blood flow in the brown adipose tissue. Now, these MRI or the PET or these are the modalities which are only available or can be used in research settings, but they are not useful or may not be available in routine clinical setting. So this here just shows on the left side we have the MRI, and the right side we have the PET scan showing the presence of brown adipose tissue. Now, brown adipose tissue secrete several factors which may have multiple metabolic functions. Out of them is the neuroregulin, FGF, the fibroblast growth factor 21, bone morphogenesis protein, as well as thyroid hormone. So these all factors are enriched in the brown fat, and they have several metabolic functions. As well as the brown adipocyte is affected by several other organs, from brain, thyroid, muscle, pancreas, liver. So several of the factors which are secreted by these organs also affect the brown adipocyte, and they regulate the development, differentiation, and the thermogenic activity. Now, so we have seen that a brown adipocyte has several metabolic functions, and in animal studies, it has been seen that the dysfunction of this adipocyte can lead to metabolic diseases such as obesity, it's been seen that the ablation of the uncoupling protein 1 adipocytes induces severe obesity and insulin resistance. And aging also leads to decrease in this tissue. And fat mass and activity have been shown to be lower in patients with diabetes, dyslipidemia, and also in non-alcoholic fatty liver disease. Now, so knowing that brown adipose tissue has such important functions, how do we increase the brown adipose tissue? If not, how do we convert the white adipose tissue to the brown adipose tissue? Now, several studies have been done. Most of the data is done in animal studies. There is very, very limited data in human studies. Now, here just is summarizing few nutritional factors which may be involved in white to brown adipose tissue conversion. Now, these various factors act by several pathways, that is sirtuin 1, AMP kinase, PPAR gamma, and all these act on the various nutritional factors act on through these pathways into increasing the UCP1 and converting the white adipocyte into the brown or the beige adipocyte. Here are a few more. Like these are the few nutritional factors, capsaicin, curcumin. They act via adrenergic beta-3 activation. These act by epigenetic modulation, increase in the mitochondrial biogenesis. So all this leads to change of the white adipocyte into the brown or beige adipocyte. So these increase fat activity. They induce a metabolic switch of existing white adipocytes, as well as they lead to new beige adipocyte formation. However, I should mention here that most of these studies have been done in animals only, and how much of this is going to affect or is going to be beneficial in the activation of brown adipose tissue in humans, that's still not clear. Now, coming to the pharmacological factors which may be effective in conversion of white to brown adipose tissue. Well, we have the serotonergic drugs, sibutramine, fenfluramine, fluoxetine. Most of these are now banned. They act via CNS and increase the adrenergic activity. Now, some drugs, rosiglitazone and pioglitazone, they have most of the studies have been done involving rosiglitazone. They activate the PPAR gamma, which again through this pathway it increases the brown adipocytes and tamoxifen. Now we see here that many of the drugs which you mentioned here are not available with us. Now, something which is available with us and which may be beneficial is the SGLT2 inhibitors. Now, SGLT2 inhibition has been shown to attenuate inflammation and insulin resistance. And it has been shown that the energy metabolism is shifted towards fat utilization and energy expenditure. Now, it has also been seen in animal studies that there is increased heat production and expression of uncoupling protein 1 in the brown fat and the white adipose tissue. Now, it decreases the M1 macrophage accumulation, while it induces the anti-inflammatory M2 phenotype of the macrophages in the white adipose tissue and liver. So these are all have been seen in the animal studies. And this figure here shows that this is the normal controls, high-fat diet. This is mice, high-fat diet plus low empagliflozin and high-fat diet plus high empagliflozin. And we see here that there is decrease in the abdominal fat. Various mechanisms by which SGLT2 can act as increase FGF21. As I mentioned, it's an important factor by decreasing glucose, insulin, fatty acid oxidation, increased thermogenesis, and increased beta oxidation. So all this may act by all these methods. So BAT as a potential therapeutic target may be possible because the mitochondrial biogenesis, dynamics, quality control, these are pathways in the brown adipocyte may serve as potential targets. Now, the brown adipocyte lipid droplets targeting the molecular regulators which govern lipolysis may also serve as a potential target, or reprogramming of adipocytes such as white adipocytes to differentiate or transdifferentiate into the brown adipocytes. So all this may be potential therapeutic targets, but as of now, I don't think we are anywhere near them. Now, the other ways how it can act is by inhibiting brown or beige precursor senescence. We decrease the death of these cells, preserving brown and beige pool size, precursor pool size. Now, chronic beta-3 adrenergic agonist treatment. This attenuates high-fat diet, but we don't have any agents which are available for use in human. Behavioral interventions, yes, chronic cold exposure activates these fat, which promotes weight loss, but a chronic cold exposure is not physiologically feasible for human beings. Physical activity, high-intensity interval training has been shown to have beneficial effects, particularly when it is done in presence of cold exposure. Now, there is also very limited data on this. A calorie restriction. So all these behavior interventions have been found to be effective in very, very limited studies, mostly in animal studies. They have been seen that they may act as increasing the activity of brown adipose tissue. Now, coming to the point that is it practically feasible to increase brown adipose tissue? I don't know. Lifestyle interventions like calorie restriction, physical activity in cold environment. Yes, it is possible if done properly, and then but it needs a very dedicated patient or a dedicated individual, I would say. The dietary interventions, as I mentioned, the various parameters, various factors, the data is available only in animal studies. The dose of various nutritional factors to achieve this has not been defined in human studies so far. Pharmacological interventions. Now, centrally acting serotonergic drugs may have had a potential, but they have withdrawn. We don't have any drugs as of now. Beta-3 adrenergic drugs still in the experimental stage, not available for use in the human beings. Now, SGLT2 inhibitors, the newer drugs, blockbuster drugs, having a lot of beneficial effects in diabetes and cardiovascular disease, they also may be promising, but more human studies are needed in terms of their ability to have effect on the brown adipose tissue. So, summarizing, brown adipose tissue is a highly metabolically active tissue, maintains energy homeostasis, and has several beneficial metabolic effects. Now, it can be a potential target for management of metabolic diseases. But I must say here that the various lifestyle, various dietary, exercise, other interventions which are being targeted, which are being thought to have beneficial effect on brown adipose tissue, as such will have beneficial effect on the various metabolic parameters. So do we really need to identify brown adipose tissue or try to increase the brown adipose tissue? I don't know. That's an open question. Quantification of brown adipose tissue is again a challenge. It's not feasible in clinical practice. It may be possible only in centers, advanced research centers who have facilities like functional MRI or different forms of MRI. The various pharmacological and non-pharmacological interventions may increase the VAT, but feasibility needs to be evaluated in studies. Again, SGLT2 inhibitors, again, I would say, may show some promise out here. Now, whatever you do, if you cannot, if you want to follow, go to extreme measures, there is this water perfused cooling vest, which you can put on and decrease your body temperature in order to increase your brown adipose tissue. But whether it is feasible or how long you can do it, God only knows. So with that, I end my presentation. Thank you very much from the Metabolic Research Group of the Department of Medicine.
Thank you, Dr. Naval. That was an awesome lecture. So to set the ball rolling, I have the first question. I think you yourself raised whether we should be doing it. What about GLP-1 receptor agonists? Do they cause browning of fat?
GLP-1 receptor agonists, there's very limited data, not much data is available in this regard. They lead to definitely significant degree of weight loss. They alter several metabolic parameters for in the beneficial way. But I could not come across any studies on human beings with respect to GLP-1 receptor agonists.
And Dr. Naval, we are using a drug, beta-3 adrenergic agonist. We're using mirabegron for overactive bladders. So that drug is already there.
Yeah.
So have you observed any weight loss in those patients on mirabegron?
No, I have not used that drug. So that drug is useful only in a selective population, but using that in patients for inducing brown adipose tissue, I don't think there is any trial in this regard. So I'm not sure about it.
And one more question that comes to my mind is there will be tachycardia and the resting heart rate will increase because we are stimulating the beta-3 adrenergic receptors. So will that not be counterproductive? You know, one way we are causing browning of fat, but we are also increasing cardiovascular risk by increasing the basal metabolic rate.
Yeah, exactly. That's what I mentioned, that there are several of these interventions that we are targeting to increase the brown fat. But we have to also look at what other effects it's going to have on other body functions, cardiovascular effects. I mean, you said tachycardia, increasing blood pressure. So whether it is worthwhile to target the brown adipose tissue at the risk of increasing the problem in some other organ, that is something questionable. And I don't think that would be, I would go for it.
Do we have any more questions from our esteemed faculty? Anybody else?